Okay, students, I lost the first part of my lecture, recorded part, so I'm going to repeat it and then post it, so it'll be up soon. So our admission of our labor patient. Our gal walks in. She goes to the triage room. We put her on the monitor. We do vitals. We do a quick assessment. We try to determine if she is in labor. The way we do that is we put her on the monitor. We check. We put her on the fetal and contraction monitor. We run a strip for about 20 to 30 minutes. We do a vaginal exam to see where she's starting, and then we decide if at 20 or 30 minutes we can get this person up to ambulate, because what we like to do is monitor them for a little bit, then get them up and ambulate them for about an hour, get them back to the room, recheck them, and see if there's any cervical change. If there is no cervical change, then they will not, probably will not be admitted to labor. They will be sent home. Even if they're contracting regularly, and even if they're rating their pain very high, if their cervix isn't changing, they are not in labor. So we will probably send her home. She may be back in 4 to 6 hours, and she may not. It's a physician decision, physician-patient decision if we decide to keep someone who is not in labor. For instance, we would keep someone who was at term, who lived far away. The physician might say, well, I'll just come in and break her water and then she'll be in labor. So, but typically if they're not in labor, they go home. If she comes in and her water has broke, whether she's contracting or not, she's going to be admitted. If she comes in and we've monitored her, we got her up to walk, we got her back to the bed, and there was cervical change, we will admit her into labor. Now, if we get her in initially and do our quick assessment, get her on the monitor, and at 20 or 30 minutes, we see that the baby is not looking really all that well, we will not be comfortable discharging her. Maybe we will recover that baby, give her some fluids, maybe do an ultrasound and see if that baby is okay to send home if she's not in labor. But typically, if babies don't look great on the monitor, we are not comfortable sending them home, irregardless of whether the woman's in labor or not. So those kind of things need to be determined. So part of our assessment is a fetal heart rate assessment, maternal vital signs, contraction assessment, cervical assessment, and fetal presentation and station. So if we check those and get a baseline, and then when she comes back in an hour after walking, there's any change in any of those baseline assessments, then she's probably in labor, and we would keep her. As far as fetal presentation, if we determine that we have a woman who's in a breech presentation, then we need to decide, well, is she in labor? If she is, then are we going to try to turn this baby to a head down, or are we going to go straight for a C-section? If she's not in labor and we have a breech presentation, then we can decide whether or not we want to try to turn this baby or send this woman, turn this baby and then send this woman home for her to come back when she's in labor, and hopefully baby stays head down. Or if she's not in labor, she's a breech presentation, the woman doesn't want to attempt to turn the baby, but she's not in labor, we will send her home and schedule her for a C-section for another date. Okay? So we have kept the woman. We're going to admit her into labor. And we're going to do all the normal history and physical, review of systems, admission data collection, a full head-to-toe assessment. But the other thing that we're going to make sure we check is any cultural or religious practices of the patient, especially if they affect diet and birthing practices or preferences. Okay, so we want to try to accommodate the patient if at all possible. Now, in labor, In the first stage of labor, first stage being when she's 0 centimeters to 10 centimeters, we're going to check her temperature every 4 hours. If her water isn't broke, and if it is, then we'll check every 2. Now, if she starts spiking a temperature, anything over 99.6 Fahrenheit, we will check her temperature every hour. What we're concerned with is if with someone with ruptured membranes that spikes a fever, then the indication is that the amniotic fluid and or membranes have become infected. And if they have become infected, then there's a high risk of baby becoming infected. So if she does spike a temp, that does not mean that we're going to go straight to C-section. We are going to determine, this is a physician call in conversations with the patient, whether or not we feel that delivery is close enough to wait for the woman to do a vaginal delivery, or if it's far enough away that we're concerned about the baby being infected, then we might start really talking about a C-section. Because there's no way, like GBS, if the woman's positive for GBS, we treat her with antibiotics, and that's actually our way of treating the baby. So the baby, it's a prophylactic antibiotic treatment for baby so that baby does not become infected with GBS, which if they do, they get really sick really fast. With infected fluids, we can't treat with antibiotics because we would not be treating the amniotic fluid, because the amniotic fluid and membranes do not have a blood supply. So that doesn't help us. You would think that, well, let's give antibiotics to babies if that's the case. And yes, we may try that, but you know, it's a really serious situation if we have infected amniotic fluid for babies. So we would like to side on the side of caution and C-section this person. We monitor blood pressure, pulse, and respirations every hour for a person in first stage of labor. If they have elevated blood pressures or heart rates, then we will probably do more frequent evaluations. We could do more frequent evaluations every 5 to 15 minutes if they have elevated blood pressures. So we need to watch those closely. Of course, we'll be monitoring pain and assisting with pain relief measures, whether that's the nurse being at the bedside, providing pressure, massage, breathing coaching, or whether we're giving medications or planning for epidural. We will palpate and assess uterine contractions every 30 minutes. And if she's on an electronic monitor, that does not release you from the responsibility of palpating uterine contractions and uterine resting tone. We will auscultate the fetal heart rate every 30 minutes for low risk, every 15 minutes for high risk women throughout their entire first stage of labor. And then hopefully she, if she's a high risk woman, she should be on continuous monitoring, not intermittent auscultation. Amniotic fluid membranes, if they're already ruptured, or if we rupture them or they rupture spontaneously during the labor, we need to assess what time the membranes broke. So that will start our time clock. And then we need to assess amount, color, and odor. So if it has an odor, then we are concerned about infection. For the color, usually amniotic fluid is a clear color. It could be blood tinged. That's normal. As long as the bleeding doesn't seem to be like an active bleed. But you may see a lot of bloody show and bloody amniotic fluid. So that could be normal. The one thing that really concerns us is if we have a green color to our amniotic fluid. That indicates to us that the baby passed meconium in utero. Babies do that when they're stressed. So it could look anywhere from just a liquidy green color like green lemonade, green Kool-Aid, or it could look like pea soup, like literally that thick in consistency. Um, so if whatever we have, if we have meconium at all in the amniotic fluid, whether it's thin or thick, then we notify the pediatrician and the NICU so that they will be in attendance at the delivery. When we have a baby with meconium stained fluid, if the baby does not come out screaming their head off, then the baby immediately goes to the warmer for the NICU team and pediatrician to intubate, to visualize cords, and then suction. So the theory is if we can do that before baby takes a breath, then we have a better chance of preventing the baby to aspirate any meconium that was in the airway. If the baby comes out screaming, then the baby has already taken a breath. If there was meconium in the airway, baby has already sucked it down into their lungs. So then we don't need to intubate and visualize cords at that point, but we do need to have more frequent monitoring of the baby if the baby starts displaying signs of meconium pneumonitis, okay? Now, the other thing with ruptured membranes is we need to be sure that we don't have a prolapse cord. So if the membranes rupture on their own, or if we break the membranes, that fluid comes rushing out, and then usually then the baby's head kind of settles down. Without that, the cushion and buoyancy of the fluid, the baby's head can settle down on the cervix. And if that occurs, that's great news. But the big risk is that the umbilical cord rushes through before the head settles down, and then we have umbilical cord through the cervix in the vagina, and then the head settles down, virtually clamping off the umbilical cord, so restricting blood flow or completely stopping blood flow to the baby. So that is an obstetrical emergency where we rush right to the C-section. But what happens is, if that cord rushes through, we will see an immediate drop in the baby's heart rate. And it won't be like decelerations up and down, up and down. Usually, if that head falls down on that cord, we get a profound bradycardia. And it stays there until we get the pressure off that cord. So what we do is a vag exam, we find the head, and we push the head up off the cord. We cannot then shove cord back up into the uterus. We cannot do that. So whoever does the vag exam and pushes that head up off that cervix, they stay there until the woman is wheeled into the OR. She is draped, and so is that nurse, and that nurse is still keeping that head up off the cord, and then they do the emergency C-section, and then they pull the baby out, and then the nurse is released from holding that. So really, really bad juju if that happens. So the transition phase, now this is still the first stage of labor. So the first stage, if you remember, the first stage of labor has 3 phases. The latent phase, which is 0 to 4 centimeters, the woman's contracting, 5 to 10 minutes. They're not all terribly painful. The next phase is the active phase. This is from 4 to 8 centimeters. The contractions are more frequent, more painful. She might be asking for pain medicine at this time. But then the transition phase is from 8 to 10 centimeters. So if this woman doesn't have an epidural, then the transition phase is very noticeable. The woman's whole demeanor will change. She will be agitated, anxious, scared, demanding. She might be writhing in the bed. This is very painful. The contractions are very frequent. And you better be checking the cervix because you need to start getting prepared for delivery. And then the second stage, so this is when she's completely dilated and she starts pushing. Okay, so this woman can push one push and pop the baby out, or she could be pushing for 2 or 3 hours. So if she is pushing for an extended period of time, then we need to be checking, doing a vaginal exam during her pushing efforts to determine that she is pushing effectively and that baby is moving down. Can you imagine someone pushing for 2 to 3 hours, and no nurse ever looking if there's being progress made, and at the end of the 2 or 3 hours, someone comes and finally checks, and she's made absolutely no progress. Baby hasn't moved one hair. So that would be really poor management, because if we determine that she is not pushing very well and not making any progress, then we can help this woman with different pushing techniques, maybe even different positions to push in to start making some progress. So we need to help her figure this out. And if she has an epidural, it might take several pushes before we can find the technique that actually moves baby. Okay. Now, our assessments of the fetal heart rate during pushing are now every 15 minutes for the low risk woman, or now every 5 minutes for the high risk woman. So this is very frequent. If you are spending 5 minutes charting, or every 5 minutes charting, then when are you, helping this woman? So a lot of times you'll see nurses charting the second stage after the baby has already been born, because it's very difficult to be charting and taking care of the mother at the same time. But it can be done. It takes a lot of practice, and then you start getting good at charting quickly, and utilizing the support system that's in the room to help mom with a few pushes while you catch up on your charting. Okay, so it's great if you can do that. And then we assess mom's vital signs every 30 minutes during pushing. So as I said before, we're helping this woman with her pushing efforts, providing support and encouragement. Women are ready to give up, especially if they've been pushing for a long time. And then we call the physician in when the baby starts crowning, and we help the physician with the delivery. So the third stage is from the time the woman pushes the baby out until she delivers the placenta. So basically it is the delivery of the placenta. So she's delivered the baby, and then however long it takes to deliver the placenta. And that could be in 5 minutes, that could be in 30 minutes. And the physician is still at the perineum and responsible for the delivery of the placenta. So initially, the baby will go straight to the mom's chest for skin to skin. All the baby cares will be done right on mom's chest as long as baby is stable. However, if there is a problem with the baby, then the baby does need to go to the warmer and taken care of. So we always have, even if we don't have meconium and don't have a NICU team there is always a dedicated nurse who is signed off in NRP, neonatal resuscitation, to care for the baby. And then the labor nurse is free to care for the mom. So we will be watching for signs of placental separation, and that is, we will start seeing more cord. The physician has got a little tension on the cord, and then we'll start seeing that cord come, and we'll start seeing a lot of blood as well. And then the physician will determine that we have gotten, he'll look at the placenta and determine that there were no placental parts left in there. Placental parts left in the uterus will cause bleeding. And then we start our frequent fundal massages, fundal checks, lochia checks. Lochia is the bleeding that the woman has after delivery. And we'll go through all those cares here in just a moment. So also, after that placenta is delivered, that's usually when we start Pitocin to control bleeding after delivery. So sometimes these women are already on Pitocin because we were using that for their induction. And Pitocin, when we start a Pitocin drip to induce a woman, we start at 2 milliunits an hour, 2 milliunits per minute, which is 2 cc's an hour. So that's not a lot, 2 cc's an hour. And then we go up 2 cc's an hour when we are increasing our Pitocin to get into a labor pattern. after this woman is delivered, we could run Pitocin anywhere from 250 cc's an hour all the way up to 999 cc's per hour. Huge change. Like, we really want that uterus to cramp, 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 consistently staying firm, and that is what is clamping off those vessels in the uterus to control bleeding. Okay. So the fourth stage of labor is the recovery stage. That could last anywhere from 1 to 4 hours, but typically on average it's 2 to 3. We will do our frequent fundal assessments and Loci assessments. So fundal assessments and Loci assessments, as well as mom's vital signs, will be done every 15 minutes times 4. That will encompass the first hour. And then every 30 minutes times 2, which will encompass the second hour, and then every hour until stable. So we are checking fundus. Maybe we're doing some fundal massage. If we find a soft fundus, we want it to firm. If we've got our bleeding under control, we can stop massaging the fundus. We will be keeping her perineum clean. We will be keeping ice on her perineum because a lot of women swell crazy. And then if they've had an episiotomy or a laceration, the ice packs help provide comfort. So here is our fundal massage. Remember to support over the pubic bone, and then with your dominant hand you'll be doing the massage. Okay, we using that two-hand method helps. It basically provides a bimanual compression. And it also protects, like if you're doing a really super vigorous massage, especially on a woman who's had multiple babies, that uterus and those tendons are all stretched out, you could possibly massage that fundus right out into her vagina. So that's the other reason why we use that cupping or two-handed method. So as I said, we will be monitoring mom's vital signs as well, along with the fundal checks. Usually it's every 15 minutes for the first hour, every 30 minutes for the second hour, and then every 1 hour until she's stable, and then it goes to every 4 hours for the next 24 hours. But if at any point you're doing an assessment on blood pressure or lochia or fundus and you find problems, then you will do more frequent assessments, okay? We monitor her temperature every 4 hours, and monitor vaginal bleeding and the fundus. Now, we also want to determine when she last voided, and if it's been more than 2 to 3 hours, we might want to palpate the bladder to see if we have a full bladder, because a full bladder will interfere with uterine contractility and possibly increase bleeding. So, depending on when she last voided, before she started pushing, or when we took the Foley catheter out before she started pushing, we may need this woman to void pretty soon. So if she's had an epidural and she doesn't have control of her legs yet, she might not have the ability to feel the urge to void or let down. So we may need to straight cath them to empty their bladder. However, usually most of the time the epidural wears off, and then we can get them up, walk them to the bathroom, and they can void. But just remember, if we're not able to do that, then we can do a straight catheterization. Okay. We also watch for perineal edema and a hematoma. So a lot of these women do swell, especially if they've pushed for a while. Some of them can swell quite large. Also, if they have some sort of hematoma growing, they can lose a lot of blood in their tissue, in their perineal and labial tissue. So we need to keep an eye on that, especially the hematoma, because if we feel like that hematoma is growing, she could be dumping a lot of blood in those tissues, and we may need to get the physician back to address that, okay? And then now we're back to the slide that I started with on the second recording. So our discharge criteria, which I did go over in the second recording.